Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about endocrine cancers with Dr. Courtney Gibson. Dr. Gibson is an endocrine surgeon and associate professor of surgery at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Courtney, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Okay, so I'm an endocrine surgeon here at Yale, and so that means I perform surgery on endocrine disorders, so organs that secrete hormone. And so the three organs that I primarily work with are the thyroid gland, the adrenal gland, and the parathyroid glands. And these organs have tumors that develop within them and oversecrete hormone, and they can be malignant or benign tumors.
So, we're coming up to Thyroid Cancer Awareness Month, and a lot of people might not be aware of thyroid cancer. Can you kind of paint us a picture of how common it is, who gets it, what are the risk factors, that kind of thing?
Oh, absolutely. So thyroid cancer actually is a pretty common cancer. It's about the 12th most common cancer in the United States. Typically, there's about 52,000 new thyroid cancer diagnoses annually. The good news about that is that the prognosis of thyroid cancer in general is very favorable. So typical, 5 and 10-year survival rates approach nearly 100% because we have very good treatment. And it largely stems from the fact that thyroid cancer is very slow growing. So it likes to stay in its own environment for a significant amount of time before it becomes widespread. And that allows us to intervene at a time point before it has become distant or metastatic. So that leads to very good outcomes.
So who gets thyroid cancer? I mean, does it target a particular demographic, whether it's a particular gender, a particular race, a particular age group?
Yeah, I think it crosses the spectrum of gender and age, but typically, like most endocrine disorders, females are affected more than males. So any benign tumors of the adrenal gland or overfunctioning of endocrine glands typically happens more frequently in females, although it can happen in both. The predisposing factors, other than gender, are specifically talking about thyroid cancer, is an exposure to a large amount of radiation during childhood. We know that patients who have had a significant amount of radiation exposure during childhood have a higher risk of developing thyroid tumors and therefore thyroid cancers in their adult life. Now, we're not talking about the typical, radiation that you get exposed to with dental x-rays or, a chest x-ray here and there or during your lifetime, although there is some data that support that there may be an association. But I'm talking more about large volume radiation exposure, like, a Chernobyl event. You were around that area when you were a child, or you received radiation to your chest area or head and neck area during childhood for a different type of disease process that was being treated. That level of radiation predisposes you to develop thyroid cancer.
What about family history and genetics? Any link there?
There is. So, the vast majority of thyroid cancers are sporadic, so they're just an event that just happens in an individual. However, there is a familial component to it, and that happens probably in about 5 to 10% of patients who have thyroid cancer. There may be a genetic predisposition. So we our concern for genetic predisposition gets raised whenever we hear of patients with a significant amount of family members who've had thyroid cancer. So first-degree relatives, parents, siblings, children. We see, 3 to 4 relatives within the same family developing thyroid cancer. Then yes, that raises the alarm that there may be a genetic component. But overwhelmingly, it's a sporadic type of event that just happens in an individual. And unlike many other cancers, it's not associated with many lifestyle factors such as drinking and smoking.
And so with it being primarily sporadic, that is to say, people who get thyroid cancer may not have any real family history, any other risk factors. Can you talk a little bit about kind of the signs and symptoms of what might make you think, geez, this could be a thyroid cancer? How are these things picked up?
That's great. I think a great question. And thyroid cancer in general is largely asymptomatic. So it just gets incidentally found. And some of the most common ways that in the patients that I see are they either have a very thorough exam by a primary care doctor, often OBGYN. Those are usually the ones that identify a thyroid nodule on physical exam, and then that leads to further workup with imaging studies. Or the patients themselves develop some dysphagia, difficulty swallowing, or sort of notice some voice changes. And because of the location of the thyroid gland and its proximity to the esophagus and the recurrent laryngeal nerves, that can cause those type of symptoms that lead the patient to investigate further. I commonly get patients to, ask, why is there not a dysfunction in terms of the hormones secreted by the thyroid gland that then, would cause them to have symptoms and seek earlier referral? And there's just not an association. Most people with thyroid cancer actually have normal functioning thyroid glands, so they're not over or under functioning. Because yes, that you would think that would lead to an earlier identification and referral.
Yeah. And so let's suppose that happens. Let's suppose that, you went to your primary care doctor who might have found a nodule or a potential nodule in your thyroid. Can you talk a little bit more about the workup? Like, what happens then?
Yeah, that's great. So typically, if a thyroid nodule is found incidentally, either during a workup for something else or on physical exam by your primary care doctor, the next step is getting a formal ultrasound because ultrasound is the best imaging modality to identify thyroid nodules and look into the more fine characteristics that make us be more concerned about a potential cancer within that thyroid nodule. So those patients get referred for an ultrasound performed either by a medical endocrinologist or a radiologist. And if they are, if the nodule looks suspicious on imaging, then that would lead to a biopsy, a fine needle aspiration. So it's a small gauge needle aspirating some cells from that nodule to then look at it and see if there's confirmation of cancer or a high suspicion for cancer based on the cytology, the cell type of that biopsy.
And can you talk a little bit more about kind of the spectrum of pathology that we can see on those fine needle aspirations? I can imagine that some of our listeners might be a little bit familiar with thyroid cancer, perhaps not, but there are different types of thyroid cancer. So can you kind of lay the landscape of what are the different types of thyroid cancers, which ones are better, which ones are worse, and so on?
Absolutely. So the most common type, which is fortunate, it also has the best prognosis, is called papillary thyroid cancer. And there are so many different subtypes of papillary, but in general, the overall category is papillary thyroid cancer, most common, best prognosis. And those are often identified and confirmed from the fine needle aspiration. These cells form papillae, hence the name papillary thyroid cancer that is distinctive to this type of thyroid cancer. Normal thyroid cells do not form papillae. They also have nuclear inclusions, so some additional findings within the nuclei of the individual cells, and this is what allows us to get that diagnosis on a fine needle aspiration. The next most common type of thyroid cancer are the follicular or Hürthle cell carcinomas, and those are harder to confirm, or actually you're not able to confirm them solely from a needle biopsy. And that's because Hürthle cells and follicular cells are normally found in normal healthy thyroid tissue. So it's only when they cluster together to form a nodule does that raise suspicion that this could be a cancer. But even with that clustering, it also could be just a follicular adenoma, which is a non-cancerous lesion, a benign nodule of follicular cells or a benign nodule of Hürthle cells. And so in those cases, additional testing has to be done to try and elucidate whether this is a cancer or a benign Hürthle cell or follicular cell adenoma. So traditionally, when we would get a diagnosis on a needle biopsy of one of those two categories, patients would have to undergo a diagnostic lobectomy, so removal of half of their thyroid gland containing that nodule in order to get a definitive answer whether or not it was a benign nodule or a cancerous nodule. But with the onset of molecular testing, we have more information before we get to surgery to give us a better idea of whether or not it's indeed a cancer. So that has been helpful, although there's work to be done within that particular category. And finally, medullary thyroid cancer is a rarer type occurring in about 5% of all thyroid cancers. That also can be diagnosed on fine needle aspiration biopsy. And also, this is one of the thyroid cancers, really the only one that may be symptomatic preoperatively. So medullary thyroid cancer comes from C cells, parafollicular C cells located on the posterior aspect of the thyroid gland. And those cells secrete a substance called calcitonin. And excess secretion of calcitonin can lead to loose stools and diarrhea. So patients can present with new onset diarrhea of unknown etiology, and that could lead to an investigation, going to the primary care doctor to figure out why they're having this symptom. And ultimately, they can be found to have medullary thyroid cancer.
And so just to kind of clarify for our audience, so you mentioned that the tumors that are follicular in origin on fine needle aspiration need a lobectomy so that we can find out whether this is a follicular adenoma, which is benign, or a follicular carcinoma, which is malignant. But with papillary and medullary, the diagnosis can be made on FNA or fine needle aspiration, yet these patients still require surgery. Can you talk a little bit more about that?
Yes. So the standard of care for thyroid cancer in general is surgery. So there are many cancers where the initial treatment and sometimes the sole treatment is systemic therapy. For example, if you're talking about a lymphoma or a leukemia, that treatment is largely chemotherapy, so a systemic type of medical treatment of that cancer. Because thyroid cancer is very localized typically, and if it does advance, it goes to lymph nodes in the local area, in the neck area. The standard of care is surgery, removal of the thyroid cancer. And so for small tumors, that may just involve removal of a portion of the thyroid gland. And so the benefit of that is that patients can maintain normal thyroid function with only a portion of their thyroid gland removed. With larger tumors or tumors that look like they're invading surrounding structures like the muscles overlying the thyroid gland or significant involvement of lymph nodes in the area, those patients need a formal total thyroidectomy, the removal of the entire thyroid gland along with some lymph nodes to properly surgically treat that thyroid cancer.
So then that leads to the next question, which is, so what are the consequences of removing your thyroid gland?
Yes, so our thyroid gland provides thyroid hormone, and the way I like to think of that is that's our metabolic hormone. It gives us the energy to do whatever it is we do every day. And because we only have one thyroid gland, if we have our thyroid gland removed completely, we have no source of thyroid hormone, and that is not compatible with human life. We have to have a source of thyroid hormone. So patients who require total removal of their thyroid gland will need to be on thyroid hormone replacement for the rest of their lives. So that's a once daily pill to take. Of course, there's the downside of, yes, you have to take a hormonal therapy. But the good side is there's not many side effects associated with thyroid hormone replacement. And there are actually many patients who actually have an underfunctioning thyroid gland separate from a diagnosis of cancer, and they also have to be on thyroid hormone replacement. So it's a very tolerable medication, but that is one of the consequences. You do have to be on hormone replacement therapy after a total thyroidectomy.
All right. Well, we are going to take a short break for a medical minute, but please stay tuned to learn more about the care of endocrine cancers with my guest, Dr. Courtney Gibson.
Funding for Yale Cancer Answers comes from Smilo Cancer Hospital, where spiritual care offers support to patients seeking peace in the midst of their cancer journey while respecting the unique philosophies, spiritualities, and religions of patients and caregivers. SmiloCancerHospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilo Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Courtney Gibson. We're talking about the care of patients with endocrine cancer in honor of Thyroid Cancer Awareness Month. Now, right before the break, we were talking a little bit about different kinds of thyroid cancer, papillary being the most common, follicular, and medullary. And Courtney, you were talking to us about the fact that all of these really require surgery, which has as a potential consequence that you need to replace that thyroid hormone. What are the other potential risks of having this surgery?
Yes, so there are important structures in the neck that are located posterior to the thyroid gland, and so therefore are at risk of injury during surgery. One group being the recurrent laryngeal nerves. So these are nerves that innervate your vocal cords. So although your vocal cords are at the back of your throat, the nerves supplying those originate down lower in the neck, and they course behind the thyroid gland. So they are a separate structure from the thyroid, but they're closely associated with the posterior aspect of the thyroid gland. So during dissection, these nerves can get injured. Tension on the nerve or traction can cause a traction injury. A stretch injury is what we call it, where some individual fibers microscopically may have been stretched too thin, and that can lead to some hoarseness to your voice. Fortunately, this is a recoverable type of injury in most cases. So typically, after a few weeks, maybe up to 6 to 8 weeks or so, a patient can have hoarseness of their voice after surgery, but it usually recovers on its own. So rare to have a long term. Now, if there's a complete transection of the nerve during surgery, then that's kind of a permanent change to the voice. However, there are some treatments available to strengthen the voice over time. But it's rare to have that. If sometimes one of the nerves has to be purposely sacrificed depending on the amount of cancer that's present. The cancer could have invaded or be just totally surrounding that nerve on one side. And so in order to get all of the cancer out, one nerve may have to be sacrificed. So that is a potential complication or side effect from surgery. Another group of structures that are important are parathyroid glands. So this sounds like thyroid, but they are parathyroid glands, meaning next to the thyroid. And these are very small glands that have an important function. They help us maintain normal calcium levels within our blood, and that's important for normal nerve and muscle function. So during thyroid surgery, because these glands are very small and hidden in fatty tissue, sometimes there could be inadvertent injury or even removal of one or more of the parathyroid glands. These glands are also located in the area where lymph nodes are, and so during a lymph node dissection for thyroid cancer, some parathyroid tissue may come out. The good news is because we have multiple parathyroid glands, we can lose one or several and still ultimately have normal parathyroid function and therefore normal calcium levels in our blood. But short term, there may be some low calcium levels that could manifest as muscle cramping and tingling in a patient after surgery. And the treatment is just to supplement them with oral calcium supplementation until those glands recover.
And so it sounds like the surgery, by and large, is fairly straightforward, particularly for smaller cancers. But can you talk a little bit about any additional treatment?
Yes, absolutely. So there are many cancers when they are small and well contained in the thyroid. The surgery itself is often curative and all that's needed. However, there are certainly a significant number of cancers that need that multidisciplinary treatment. So if a person is found to have a large cancer within the thyroid gland and there's lymph node involvement or local invasion into surrounding structures like the muscles overlying the thyroid gland, we know that cancer has escaped the thyroid and gone into those soft tissues or lymph nodes, and therefore additional treatment is necessary. So the next most common treatment in addition to surgery is a form of radiation called radioiodine therapy. And this is a very targeted therapy to treat cancer that has gone beyond the thyroid gland or is at high risk of recurrence. Iodine is, you think of it like a salt. It's essentially a salt, right? But it's this particular type of salt, it's only absorbed by two different types of tissues, normal healthy thyroid cells and thyroid cancer cells. So when a person has undergone a total thyroidectomy for thyroid cancer and they are in need of radioactive iodine therapy, then we're talking about dealing with microscopic level disease or low level disease that has escaped the surgery. And it's a very effective treatment and does not cause the typical side effects you think about when you think about radiation treatment for cancer. So it's not external beam radiation that has a significant side effects is localized radiation, where the only cells that are going to absorb the radiation are the ones that absorb that iodine tablet, and that's going to be thyroid cancer cells or any thyroid remnant of normal thyroid tissue. So a very effective additional adjuvant treatment after surgery that some patients need. And then lastly, you mentioned endocrine therapy. So one of the treatments is suppression of thyroid stimulating hormone. So there's typically two different groups of hormone, that comes directly from the thyroid gland or what gets supplemented with a pill once the thyroid gland is gone, and then that gets secreted from the brain, thyroid stimulating hormone. So the way to think about it is when the thyroid gland is gone, the brain is going to think that you need more thyroid hormone. And so the brain will send out thyroid stimulating hormone in an effort to raise those thyroid hormone levels. So let's say, a single cancer cell has escaped the thyroid surgery and has also escaped the radio iodine therapy. The tertiary treatment is to have that patient be a little bit hyperthyroid, a little too much thyroid hormone in their system, not enough to cause significant side effects of overactivity of the thyroid gland, but enough to suppress the secretion of thyroid stimulating hormone from the brain so that one single cancer cell does not get stimulated. So that's an additional treatment. And then there's tyrosine kinase inhibitors or immunotherapy, which has promising results in the more difficult to treat thyroid cancers.
Before the break, you had mentioned that there are new diagnostics, molecular diagnostics now that are helping us to really understand, particularly for follicular biopsies, whether this is a cancer or not. Can you talk a little bit more about the molecular genetics, the molecular biology of these thyroid cancers and how that's being used in clinical practice?
Sure. So in general, thyroid nodules in general are very common, and fortunate for us, most of them are benign, even though thyroid cancer is on the rise, it's just being found more frequently. When we do see nodules within the thyroid gland, sometimes these nodules have certain characteristics that are a little concerning on imaging. So they may have microcalcifications, little white specks within them that raise concern for cancer but don't directly confirm cancer. They may have hypervascularity. They look a little bit more vascular than a typical thyroid nodule. And so those warrant a fine needle aspiration. Now, sometimes we get a very definitive answer. This is a benign nodule, so the chance of this being a cancer, we never say zero, but we say essentially, 3% or less, and that's virtually zero, versus this is definitely a cancer. But there's a large group of these thyroid nodules that are indeterminate nodules, and follicular and Hürthle cell neoplasm fall into that. And that means that some of these cells that we have aspirated look like normal thyroid cells. Some look a little bit atypical or abnormal. So there's not enough for us to safely say this is a benign nodule and not enough for us to confirm that this is cancer. So prior to molecular testing, when we would have these indeterminate nodules, the most we would get back is the risk of, depending on it, a thyroid nodule with atypia of unknown significance, for example, is an indeterminate nodule that carries roughly a 15% risk of cancer. A follicular neoplasm or Hürthle cell neoplasm is a indeterminate nodule that carries roughly a 30% risk of cancer. And so, that is the level of significance for that risk varies from patient to patient, but that's the best that we had at the time prior to molecular testing. So there would be some patients who had that 15% risk and that was too much for them. They wanted that diagnostic lobectomy. There are others who wanted to continue with watchful waiting. And on the flip side, there were those with a 30% risk who wanted watchful waiting while others wanted surgery to get a definitive answer. So with the advent of a molecular testing, we've been able to risk stratify these indeterminate nodules better. So now an atypia of unknown significance with molecular testing can turn into actually this is the same risk of a benign nodule, 5% or less. So we can just watch it and we don't have to intervene. Or actually with molecular testing, the risk is 50% or 70% that this is a cancer. And so patients tend to want to be more aggressive in the treatment of that. The one category that molecular testing hasn't proven to be as effective in giving us the answers we need is with the Hürthle cell neoplasms. So we still get, a kind of 50-50 kind of response where we still don't know with molecular testing, is this cancer or not? Because some of the mutations that are found with Hürthle cell neoplasms are also some common mutations found with benign nodules. So I think there's been a lot of benefit. We get more information in these indeterminate nodules that helps us make better offer better advice to patients regarding surgery or not, but there's still work to be done in that area.
And then another thing that you had mentioned in passing was, some of the systemic therapies. So, we often talk about targeted therapies. So, for example, for breast cancer or for other cancers where there are particular mutations that we have drugs that can target. Those mutations, essentially being very good in terms of what we call personalized medicine. Now, in terms of thyroid, you certainly had mentioned radiothyroid therapies. Are there other systemic therapies that take advantage of this personalized genetic mutations, or do we not really kind of look for those mutations in thyroid cancers?
So we do look for mutations in thyroid cancers, and that's what that molecular testing is helpful for. So there are certain mutations that carry a higher risk of thyroid cancer, like an NRAS or an HRAS mutation, a RET mutation, and these are types of mutations that we can use targeted therapy for. One thing that's kind of on the horizon there are some patients who present with very aggressive thyroid cancers, and they are deemed unresectable at centers at times because they have grown and invaded locally into important structures like the trachea, the larynx, things where you just can't remove completely these structures, or it'd be too morbid of a surgery to treat these patients. And, this is a new area that we are working on here, where we're trying to treat these patients with immunotherapy or systemic therapy in a neoadjuvant manner, meaning before surgery, in an effort to shrink these nodules and shrink these tumors so that they then can become resectable. We found this to be beneficial with these really locally advanced tumors. And again, we have limited experience thus far, but the experience that we've had, we've had 3 patients who have gone from unresectable to resectable, and that's of great benefit to the patient. Also with medullary thyroid cancer, the only effective treatment for medullary thyroid cancer is largely surgery. So we're looking into ways to see, is there a systemic type of therapy or treatment that can help those patients who have recurrent or ongoing medullary thyroid cancer, and tyrosine kinase inhibitors play a role in that as well.
Mm-hmm. And so the other question that we have is, for the patients who choose watchful waiting, who might have a thyroid nodule of indeterminate significance, but we think that the risk is pretty low, how are these patients followed?
Yes, so those patients, and it's very important, they need to be followed by someone who has experience in watchful or expectant waiting when there's a known thyroid cancer. So we have learned a lot from studies abroad, particularly in China, where patients have had a biopsy-proven small thyroid cancer, maybe 2 centimeters or less, and those patients have been watched or observed and managed for years, even decades, and some of those nodules stay exactly the same size. They don't grow, and those patients continue into being under active surveillance, whereas others grow, and now you start to see some lymph nodes that look a bit abnormal, and then those patients get transferred over into a treatment program. So we have some useful information from seeing what has happened internationally.
Dr. Courtney Gibson is an endocrine surgeon and associate professor of surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.